guys, welcome back to another Colorful Keto with Dori. We figured it out. We're going to do this as a voice call, and you guys will have to wait on Instagram till we get all done, but I'll share it there too. So, welcome, Dr. Serrano. We're so excited finally. Introduce yourself, and then we're going to kick off the day.
Thank you for having me, Dori. I guess it wouldn't be one of our videos with some kind of, without a technical difficulty. So, we lived up to the expectation, I guess.
Right.
But we're working on it. We're perfecting it. So I'm Dr. Serrano. I'm the medical director at Baja Group. And we're basically a practice that sees patients from all around the world for different specialties. Most of our patient base is from the U.S. and Canada.
Okay.
We do see people from across the Atlantic Ocean as well, though. And our main specialties are bariatric surgery, plastic surgery, orthopedic surgery, minimally invasive spine surgery, fertility medicine in the form of IVF and other modalities, and alternative cancer treatments, among others.
I love the variety that you provide at your clinic. And what I want people to know is it's a small clinic. It's very intimate, personal health care. Where I live in Canada, it's really not like that. You really feel like you're a number in a sea of numbers. And
Right.
When I came down and met you, it was the first time I think I ever experienced what I would consider customer service based medical care.
Well, yeah, I think I was just talking about this with a patient from Canada, actually, that left yesterday. And we were talking about how, really connecting with the patient, it is almost like a lost art, And so I'm not saying it's the physician's fault. I think, as a system, we're trending into losing some of that. But it's something that we're it's very close to us, and it's a high priority for us to be able to chat with every patient and really dive in to see what exactly is going on and how we can help.
Yes. So before we got all connected, I was telling everybody that I did not see as much in my news feed about PCOS awareness as I thought I would this month. And I really kind of expected, with it being PCOS Awareness Month, to see it flooding everywhere. And I still feel like it's such a taboo that nobody wants to talk about. So let's start there. And I kind of want to ask you, and I'm putting you on the spot, but why? Why don't people want to talk to their doctor about these issues? Why do we, get nervous when it comes?
It's a complex hormonal disorder that can start right when a woman has her first period, when menses arrives. And so, as I'm sure we all can agree, it's a difficult age. Teenagers can be a little volatile during those years. And when you add on top of that an extra hormonal imbalance, younger women won't be as inclined to mention it to their parents, and or their physicians. So, let's start with the basic thing. What is PCOS? So,
yes.
Polycystic ovarian syndrome it's a hormonal imbalance, a hormonal disorder. Okay, and it affects mainly the ovaries of women that are in their reproductive ages. Okay. Most likely it starts in the teen years, and at the very basic concept, so I won't bore you with a lot of biochemical lingo here, is that you have these balloons that are fluid filled around the ovaries, okay? And what they do is that they impede normal ovarian function so that the ovaries aren't able to secrete eggs or ovules, which are the agents that contain the genetic material, in this case the X chromosome, that will be later fertilized, hopefully by a sperm, in order to be able to conceive a child.
Okay. That's
basically what PCOS is. And so women can have sometimes very long periods, or they can have a complete absence of periods. period, which is called amenorrhea, or dysmenorrhea, which is basically that it's all over the place.
Okay. In my personal experience, I've found women who have extended periods are more likely to seek out treatment than women who don't have periods. Because the women without the periods are like, what? Footloose, fancy free? Hello? Does it matter?
Yes.
No.
Yeah, unfortunately, when PCOS is first auto-detected, women will say, well, what do I even need a period for? Okay, but the reality is that it is something that should get, looked at, tested, and when the symptoms are and the signs are there, it's definitely something that should be brought up, because there are a lot of things that are kind of circling around when PCOS is a problem. There are a lot of causes, it's a multifactorial condition, so basically means that it has a lot of places through which it originates. Now, when you have a lot of insulin roaming around in your bloodstream, such as the case when you're eating a lot or you're grazing a lot, whenever you eat and there's glucose in your bloodstream because there are insulin spikes. So when the insulin spikes and is just at a high concentration in the bloodstream, it can be one of the reasons why these follicles can start growing. And so insulin insensitivity, like is the case with diabetes, can also be very closely tied to PCOS as diabetes as well. And so these are things that have to, be a red flag to either parents or patients, because it's not necessarily just in the teenage years. It can develop later in life, even, when women are becoming pregnant a little later in life nowadays. But it still can show up in the late 20s and mid-20s. And so it should be looked at just so that it doesn't become a big problem later in life. And so that you can address it. And by the time a woman wants to get pregnant, she will have the ability to try to conceive whenever she and her partner want to.
Okay, so that's my next question. Because I feel like a lot of women feel like it's not a problem until they want to have a family. They'll go to the doctor and say, well, you know what? I've had irregular, painful periods. I've had cysts probably since I was, 13 or 15, but now I'm 35. I'd like to have a baby. Let's start working on that.
Yeah, so PCOS can become a big issue when patients want to finally conceive. So for example, we see a patient, that maybe early 30s, that maybe a little overweight, may show a little more increased signs of hirsutism or just her body hair. Acne is usually a problem. And so those are the tell signs for a woman that most likely will have PCOS. Now, what we usually do in those instances is that we'll tell the patient, we'll run some lab tests, and we will do a transvaginal ultrasound. And so usually when you do the ultrasound, it's very evident. You see the increased number of follicles, hence the name, and we can make a diagnosis right then and there. So usually when we do lab tests, certain parameters are elevated, including one that's one that we always ask for when it comes for patients that are doing IVF cycles, which is anti-Mullerian hormone, or AMH. So basically, AMH is going to tell us how well the ovaries of a woman are working. What their ability is going to be able to secrete eggs into the fallopian tube so that they can get fertilized by a sperm. So the problem here is that sometimes women that have, most of the times they have PCOS, they're going to have a high AMH, or anti-Mullerian hormone. But that doesn't mean that they're going to have a higher probability of becoming pregnant. It's actually quite the opposite. So when we're faced with that issue, what we have to do first is we have to tell the patient, well, you have a few options. So the first one is usually to try to lose some weight. So when you lose at least maybe about 20 to 30% of the excess weight, not the total body weight, but the excess weight that a woman may have. So just to keep math simple, if you happen to be 100 pounds overweight, if you lose 30 pounds, then your the PCOS, the parameters that we look for, like the cysts, the follicles that we see over the ovaries, can substantially diminish to a point where you can actually become pregnant a lot easier. So weight loss is one of them. Eating well, obviously, which they come basically hand in hand, which is going to lower insulin levels in the bloodstream. And I mean, when diet isn't something where the patient has tried diets and just can't get it to happen, there is a surgery that has been shown to help, and that, you know, people call it to be a cure. I don't like the word; it's a little too heavy for me. But when you undergo bariatric surgery, specifically a vertical sleeve gastrectomy or even a gastric bypass plication, you can actually reduce, obviously lose weight, and basically the PCOS is undetectable in the patient. So that's why people say it gets cured. But like I said, it's not a word I like using. Now, once that happens, then women usually will have a much easier time to become pregnant. And thus, you know, the probabilities are much higher to be able to conceive. Sometimes even without IVF.
For me personally, I found that after I had my gastric sleeve plication, a lot of those symptoms went away, and I lost a large amount of weight in the first 6 months. But I was never diagnosed with PCOS. So I want to ask you, how many of these symptoms should we be feeling before we go to the doctor and say, hey, is this an issue? Because when I look at the list of symptoms, I could tick every single one of those boxes, but I never thought, A, it was an issue, B, it was anything anybody could fix, or C, let's be honest, I didn't feel like my period was anybody's business but my own.
Right. Yeah, exactly. You know, I mean, I'd advise patients that whenever the menstrual cycle, I mean, it's called a period because it has a period, it has a cycle, right?
Okay.
So we should see some uniformity in it,
Okay.
I would say that as soon as you see that, talk to your doctor, you know, especially, you know, right now, since it's PCOS Awareness Month, I mean, it is something that is very understated, and we as doctors need to do a better job of talking more about it with younger patients, and when we may see the signs or the symptoms. And so when maybe your period is somewhat regular, or it becomes regular and then irregular for a bit, so you're not sure if you fall into that category, and you may be exhibiting certain signs like the triad, where you have increased body hair, when you see obesity, and when you see a lot of acne. And so it usually happens obviously in the face and the neck region, and also around the trunk of the body. You can see it. So if that in combination with an irregular menstrual cycle is an issue, I'd say get it looked at.
Okay. And our Joette, I love Joette. Hello, darling. Shout out. She would like to know, can you still suffer the symptoms of PCOS after complete and total hysterectomy? She had absolutely everything removed, but she still feels some symptoms.
Okay. So some of the symptoms, like, for example, the hirsutism and the acne, can be because of excessive androgens.
Okay.
And so your body's still going to have the capacity to produce these androgens, even though you may not have your ovaries anymore. So if there was in fact, the total hysterectomy, that not only the uterus was removed, but the ovaries as well.
Yes.
Then you definitely have to see your doctor in order to get some labs.
Okay.
Specific labs in this case, in order to look at the adrenal cortex and other organs that work in that axis to produce certain hormones, in order to see what exactly is going on. Because most likely there's going to be an imbalance. Now, if you just had a total hysterectomy, you will undergo a period of until you normalize and you stop seeing these symptoms. But if they've been persistent for a while, I would definitely pursue your doctor to get more labs.
Okay. Joette says her acne is gone. That part of it has decreased, but the insulin resistance and those hairs, those hairs. And that is actually what I noticed at the beginning of PCOS month. I came across a post of a woman saying, you know what, if you don't know what PCOS is like, I'm going to show you how I shave my entire face every day. There you go. So I want to talk a little bit about that, because as a woman, I think that is got to be one of, yes, it's only superficial. Yes, it's a prettiness thing. It's not a pain thing. But I think for a lot of us, we struggle with that, because how do you feel feminine and beautiful and attractive when you're like, okay, I have a full beard now?
Yeah, I mean, it is a very difficult and very challenging, I mean, to say the least, understatement most likely. And, you know, women that undergo this struggle, I mean, I'm sure they will find the right words to explain it, but I can just say I'm sure it's very difficult. We've seen patients that battle through it. And the honest, I mean, it goes back to the same response there to Joette.
Yes, Ms.
So,
Joette.
yeah, I mean, because the precursor to testosterone, to androgens, is going to be a steroid precursor. And those, I mean, it's a very basic molecule, and from there it can be produced to a bunch of different compounds. And so what you have to do is we have to see where that axis from where there is a stimulation, maybe from your central nervous system, all the way down to your pituitary gland, and to some endocrine organ in your body that is producing maybe some excessive testosterone or some other androgens. Okay. So we have to see where that's coming from in order to be able to attack it from the source, and not just be, you know, shaving or using, creams in order to remove the hair. We want to attack this from the source if possible.
Well, and I think that's a lot of us are stuck in treating the symptoms. We care about the facial hair. We really care about the miserable cramps, and the rest of it, we're like, well, I mean, does it really matter all that much? I mean, it matters that I can't get out of bed 5 days out of the month, and it matters that I feel like a hairy beast, but I feel like some of the other symptoms kind of just slide under the rug and get swooshed into our everyday blah that we feel.
Yeah, no, I agree. And that's the importance of, and this goes back to what I was initiating the conversation with, you know, having a good rapport with your doctor. Because, I mean, if you've seen your doctor maybe for a total of 5 minutes in the last 5 years, well, it's going to be a little difficult. So establishing good rapport with the doctor, physician assistant, with the nurse that you usually go to see, usually this will be easier to spot, and it won't go undiagnosed and hence untreated. Because some patients, you know, once it's identified, there is some medication that can be given. You know, some doctors will give, for example, metformin, which is a medication that's given to diabetics, and it's something that can help with PCOS. And so there are first lines of defense, and then, you know, as you escalate, you start going to medication, and like I said, possibly even surgery.
Okay, so I know that a lot of the women in my following, they're right in that mid-30s where, you know what, maybe they'd like to have one or two more kids. You know, they've done the stuff. They've lost the weight. They're eating good. They're, you know, kind of trying to get their hormones under control. And I say kind of trying because there's only so much that you can do. Joette has gone all the way down to carnivore, and she's still having some adrenal fatigue and some hormone level issues. But when my ladies are at that point, and you're like, okay, this is do or die time. Either I'm adding to my family or we're giving up on that idea. I want to talk a little bit about where those ladies can go, because I feel for them in that sense.
It's something that we deal with on a daily basis.
Okay,
so let's talk about how this is tied to fertility or infertility.
Okay.
Okay. So let's say a woman is, let's just say 35 years old. Okay. Which is very young. Okay. But for reproductive reasons, we can start to raise an eyebrow if that woman has not been able to get pregnant, to become pregnant. So let's say the partner has been tested and the seminogram revealed that everything was working just fine. But let's say with the woman, we know that there's PCOS already. Let's say we've established diagnosis.
Okay.
And let's say the patient says, you know what, doctor, at this point, I just want to give it a shot, which happens sometimes. Okay, so usually what we tell those patients is, first off, let's say the patient is from far away.
Okay.
So we would try to have her GP or OB-GYN do a transvaginal ultrasound to visualize the ovaries and to see how many functioning follicles we can identify within the ovaries, not surrounding like the PCOS ones, but basically the ones that can yield an egg. Okay, so that, for example, we can say in a healthy 35-year-old woman that there are 4 follicles on the right ovary and 4 follicles on the left ovary. Okay. And so what we do is we can tell her, well, we have a good chance of, with medication and with an IVF cycle, with in vitro fertilization, to stimulate the ovaries, in order to extract, like I said, those follicles, inseminate with the male's sperm sample, and then transfer to be able to conceive. Now, there is another treatment that can be done. Maybe a couple says, well, I don't want to do IVF. Okay, well, we could do something called an intrauterine insemination. Okay. But, I mean, the challenge is still going to be the same, because basically with an IUI, what we do is we're going to do a direct injection of the sperm into the cervix or into the uterus of the patient. Okay. And so the sperm are still going to have to find a viable egg in order to work. So, I mean, even though we're doing a directed injection, that doesn't mean that the probabilities are going to be higher, because we still have that limiting factor. Okay, but it is a possibility if the patients want to try that before. Okay. Because we're still going to give some medication in order to stimulate the ovaries. The big difference between an IUI and an IVF is that with an in vitro fertilization, we're going to physically extract the eggs. We're going to take them to our lab. We're going to fertilize them with the sperm sample. And then once we get an embryo growing in the couple of days old only in our lab, we will transfer it into the uterus. Compare that with an IUI. With an IUI, basically what we're doing is we're doing a direct injection basically into the uterus after pre-medicating the woman in order to have a greater ability to be able to produce a couple of more eggs, hopefully, in that menstrual cycle. Okay. So that, I mean, the reality though is that a patient that has PCOS is going to benefit more from an IVF cycle. Now, there are some taboos about IVF and that all sorts of things can happen. I mean, in 2019, most of those issues have been addressed, and now we even have extensive screening tests where you can basically map out the whole DNA of the embryo that you're going to be using, or the embryos that you will be using, so that there isn't a trisomy 21 or 321 chromosomes like in Down syndrome, or that there isn't issues where you only have one copy of one chromosome. And so all those things you can actually know before you even transfer the embryos back into the uterus. So, I mean, technology has advanced a lot in the IVF world, so that, I mean, maybe you're in your early 40s and you say, gosh, well, I don't know if I have the energy in this stage in my life to be able to cater to a child with specific needs. And so that's why patients are given these tools so that they can make the decision.
Okay. And one other question I wanted to ask you, because I see this pop up all the time. Do you increase your possibility of having multiple births when you're doing an in vitro fertilization technique?
Yeah, so that it is possible, okay?
Okay.
So here in our practice, what we'll do is we will do, so let's go back to that example of the patient where we obtained 8 embryos. Okay, so let's say that after they were in our lab, or in the initial evaluation, our biologist said, you know what, only 6 of those 8 are good quality eggs. And so the other 2 we dispose of. We have 6 now, right? Which is a normal number in a woman of that age. And so those 6 eggs or follicles or ovules, we will fertilize with the sperm, okay, to obtain embryos. Once we obtain the embryos, we will allow them to incubate in our lab. And in about 2.5 days, we can see where in the division cycle they are. Okay. So if out of those 6, we have 2 that may be lagging a lot, then we will not use those embryos because most likely they won't fully develop. Okay? So the 4 that are left, we can actually transfer all 4 of those back into the uterus. Okay? And that is going to increase your probability of having 1 successful pregnancy. Okay? Now, yes, we do have twins every once in a while with IVF, but 3 or more births are very rare. Okay, so there is or sometimes patients say, "Gosh, don't transfer 4 or 5 embryos because I can't afford to have 4 babies." Right? Yeah. So we tell them, no, it's not really going to be the case. That will basically just tilt the odds in your favor to have 1 successful pregnancy. And so now on the other side of the coin, there are some couples that are maybe in their late 30s, early 40s that say, well, I want twins, but it's not something that we can guarantee just by, or we can't just inject a lot of embryos. Number one, it's unethical, but you also have to understand that multiple pregnancies are also going to yield a higher risk pregnancy, and so that can become an issue as well.
Okay. Joette says, I have a very good relationship with my GYN. He's my uncle. That only happens in Arkansas. She said, I just wanted to know what to tell him or what to ask him for or what kind of tests he can run for her, because she does talk to him almost every day, but she's not sure what to ask him for.
Yeah, well, I would just go straight up to the OB-GYN. He's going to know. And you would say, hey, uncle, can I get a full female hormonal panel and androgens to be tested in my blood and my serum? And that will immediately give you at least a starting point to where to begin looking, whether it's going to be with an abdominal ultrasound, a pelvic ultrasound, a CT scan, more lab tests. But at the bare minimum, you need the basic lab tests, and I would start with the female hormonal panel.
Excellent. So I think a good question to wrap up on is, are we ever going to shock our doctor talking about these personal things? I think 9 out of 10 women don't want to talk to their doctor, mostly because of their own personal, well, I don't want to make him uncomfortable. I don't want to make it weird. I have to see him all the time,
Dori, I've heard it all. Everything from, just uncontrolled flatulence to, you hear everything, okay? But, the important thing to remember is that we're here to help you. And, I wouldn't, I would say no doctor would laugh in your face or make you feel uncomfortable for opening up, especially when it comes to young teenagers that are undergoing through a difficult transformation, to go from being a young girl to an adult. Yes. And so when that happens, we have to do our best to make the patient feel comfortable. Yes. And, sometimes that means delegating to a female colleague and say, hey, can you step in and talk to this patient? And we have to also be able to identify when maybe the patient is trying to say something, but that she would be more comfortable with a female doctor. That's fine. At the end of the day, what matters is that it gets addressed and that the patient gets treatment, or at least now has a roadmap to what to do in order to address this.
Okay. And I know I said that was the last one, but I just thought of one more. Should we be watching our daughters and our granddaughters? Is this something genetic? If we have these issues, should we be keeping an eye out when our daughters and granddaughters start their periods?
Yeah, I mean, it does have a genetic component, okay? There is a hereditary part to PCOS that can make you be a little more predisposed to having it, okay? That doesn't mean that if you had it, for example, that your daughter's going to have it. That's not the case. Okay. But it will make her more susceptible. And all the better in order to start the conversation early and make sure, at least to start with the period, because sometimes they be talking about body hair, body image can be a little more challenging with teenagers. Yes. But maybe when the conversation starts about the period and, make sure you tell me or you let me know if there's something wrong with your period. You should expect it every month. If it doesn't, let me know, and so on and so forth.
Excellent. Well, thank you so much for your time and for educating us a little bit more on PCOS today. We really appreciate it.
This is, the disclaimer is that this is the tip of the iceberg.
Yes.
Obviously, this is an informative talk, and I mean, everybody should, not take this as a full-on consultation, but as an awareness, that if this rings a bell, that you should definitely talk to your doctor in a personal way so that this can be addressed. It's like when a patient contacts us through, social media or email, how much does this cost? Well, we're talking about a medical procedure. We would like to get to know you a little better to see what it is that you want and what we can offer, so that it's not like you walking up to a convenience store and saying, how much is this or that? The medical world is it's basically like tailor making everything for you, the patient. So take the time to be able to talk to a physician rather than being shopping around for answers or for prices, for that matter.
And we will be covering this every few months. So if you guys have questions, send me a message, write it in group. And this is something that I think there's enough here, enough women that we know that are struggling with it, and enough information that we can feasibly cover this every couple of months so that people are always aware.
Yeah, there are just so many ramifications to this that, of course, if something comes up, I'd be more than happy.
Excellent. Well, thank you so much for your time, and enjoy that lovely weather. I'm not at all jealous.
Yes, it is nice and sunny, so I heard you guys got snow in it, so I'm sorry. But,
like 2 feet. Hopefully when we chat again next month, it's warmed up a little.
Hopefully. Okay.
Thank you so much. Have an amazing day.
It was a pleasure once again. Okay.
Yes. Take care. Bye.
Bye-bye. Take care.
Okay, so I'm going to flip you guys around. This one kind of ended up weird, and I have to tell you guys the funny. I told you, I brought TikTok with us to go live with us. They got kind of a weird angle. I got a notification that said, I'm broadcasting copyrighted material, and if I don't shut it down right now, I risk getting blocked. So I don't know what we were discussing that could have been copyright material, but cross your fingers for me that I'm not blocked off of going TikTok live. I hope you guys have an amazing Monday, and if you are one of 1 in 10, you don't need to suffer alone. Find us. We're here. We're figuring it out together, and we're having a good time. Have an amazing day, guys, and I'll see you soon. Let's get our dancing song back, just because. I don't think that was the copyright thing from TikTok, because it was TikTok's music. Oh, see you guys later.